So I'm going to introduce back up Dr. Brenner, and she's going to speak to us on contemporary treatment of blunt thoracic aortic injuries. Welcome back.
All right, thank you. Good afternoon. Hope everyone had a good lunch. And I know it's a struggle to stay awake, but I'll do the best I can. Again, my disclosures. As you all know, blunt thoracic aortic injury is the second leading cause of death. The majority occur from motor vehicle accidents or cases where the body is in rapid deceleration. Most patients with blunt thoracic aortic injury actually never make it to the hospital. Most die in the scene. The deceleration mechanism, part of the aorta that is mobile and part of it is fixed. The area that's fixed is just distal to the left subclavian at the ligamentum arteriosum, and that is the most frequent location of injury due to the mobile area of the aorta. But the fixed portion, which is typically injured in most cases, is either a grade 2 or grade 3 injury. So how do we diagnose these injuries? Usually we can have a high degree of suspicion based on mechanism, so the history and the physical exam. The chest x-ray, as you all have heard, the widened mediastinum is an indicator of potential aortic injury. The reason why it shows up as wide on the x-ray, it's radiopaque or radiolucent, is because the hematoma that forms around the aorta makes it appear white on the x-ray. So the widened mediastinum is due to blood around the aorta. Usually, patients that have a suspicion of blunt thoracic aortic injury undergo a CT scan, right, CT angiogram for diagnosis. And then even if the CT scan is equivocal, there's a question, we need more information, there's at least 2 other additional diagnostic modalities that we can do to either confirm or rule out blunt thoracic aortic injury. One is IVUS that I'll talk about, as well as the angiography. So the CT scan is the most common way that we identify these patients. Different features, usually a pseudoaneurysm, as I mentioned, a grade 3 injury most commonly. And these are also the ones that are most commonly treated. So the mediastinum can appear really uninjured at all, but there are times when you see a lot of blood in the mediastinum. There can be a shift. There's usually associated rib fractures, especially high rib fractures like rib 1, some hemothoraces, lung contusions as well, not surprisingly, especially for blunt mechanisms and thoracic injury overall. The aortogram, it used to be the gold standard, right? Before we had CT scans, patients went to the angiography suite and had a contrast injection, and this was a great way to be able to see most often type 3 or grade 3 lesions, pseudoaneurysms, but also angiography is sensitive enough to pick up large intimal flaps and dissections, which are grade 1 and 2, as well as some intramural hematomas. IVUS, for those of you that are not familiar, it's essentially it is a tiny ultrasound that goes up over a wire, just like a lot of the endovascular devices. At the end, there's essentially an ultrasound probe that looks at all the layers of the aortic wall. It does not require any contrast. There's no radiation associated with it. And it gives really very real-time and accurate measurements, both of diameter, thickness of the injury, morphology. You can see plaque. You can actually see color flow behind or above and below lesions that are associated with injury. So it's extremely sensitive and been demonstrated in at least one study looking at the comparison between CTA and IVUS. And IVUS has been shown consistently to be more sensitive than angiography for these specific lesions, particularly because it's an image from the inside of the aorta out, and we can see all the layers of the aortic wall, especially those that are injured. So if we look at historically in the literature about treatment for blunt thoracic aortic injury, the two sentinel papers are the AAST trials, 1 and 2. The first one was really looking at mostly open aortic repair, since the endovascular area had not come along quite as far. Both were prospective and multi-center studies, 193 patients. And the second one, there was a high degree of TBR-specific complications. So TBR is the thoracic endovascular aortic repair. 20% significantly high complication rate for this procedure. There was a transition in diagnosis from the first AAST trial to the second. That's when more patients went from being open repair to TBR. The angiography and echo was soon replaced by CTA in most of the 2008 patients. There were improved outcomes with transition to TBR, so the outcomes were better with endovascular therapy. The mortality was shown to decrease. The paraplegia rate was also found to decrease, and these are really in line with the same findings that the vascular surgery literature was demonstrating in their outcomes with thoracic aneurysm repairs and TBR. Again, more patients were showing or demonstrating that survival was at least as good if their repair was delayed. So if they had other injuries that required more important or more rapid treatment, that delayed repair was actually becoming quite acceptable. Now, is TBR and stents the whole answer for blunt thoracic aortic injury? Well, we needed a common nomenclature guide. There are several grading systems out there, certain ways to distinguish a hematoma from an intramural hematoma, from a transection, from a dissection, from a complete leak. So the type of treatment provided is really one of the things that is driven by a common nomenclature guide. Another nomenclature guide is helpful to really let us know what's the timing of intervention. So for a grade 1, does it need intervention at all? For a grade 3, does it need intervention? And when should we do it? Do we need to do it right away because that pseudoaneurysm is going to rupture in the next 2 hours? Or can we actually put the patient on a beta blocker and wait at least 12 or 24? So the common nomenclature guide must also work across a spectrum of injuries. And the AAST injury scaling and scoring system also denotes thoracic aortic injury in the descending part of the aorta. So if we look at the layers of the aortic wall, when I mentioned the IVUS, the ultrasound that looks from the inside and out, we see the intima, the really thick media, and then the adventitia on the very outside. So there's definite differences in injuries to these three portions of the aortic wall. And really, we're still kind of trying to answer the question, how long can we wait to treat some of these injuries, and do they even need to be treated? So one of the standard grading systems, 4 grades, grade 1 through 4. Grade 1 is just a small intimal tear. Grade 2 is a hematoma that forms in the media and in between the adventitia and the intima. Grade 3, as I mentioned, is a pseudoaneurysm, which is a little bleb, and they can be as tiny as almost undetectable on CT. Maybe you see it on one slice, or they can be extremely large. Grade 4, you've all seen or probably at least heard about these, and these are the frank ruptures. So the treatment algorithm traditionally for grade 1s, usually routinely, people just observe them. Maybe medical treatment if they don't have any contraindication, antiplatelet therapy. Grade 2s and 3s is kind of still actually where the debate comes across. So for a grade 2 or 3, do we do a TBR, or do we do open repair, or even are there some that are small enough that we can actually just leave? The answer is still up in the air. Grade 4 obviously needs absolute repair. That is a rupture, an impending death if it is not treated rapidly. So again, the question becomes, is repair mandated? So as I mentioned before, some of the pseudoaneurysms, the grade 3 injuries, some of them are extremely small. You see them on one cut of a CT, and you just sit there and look at them and think, oh, what's going to happen now? Is it going to get bigger, smaller? How many times do I have to scan them again? But the question is that small pseudoaneurysm, is the risk of rupture for that the same as the picture on the right for a huge pseudoaneurysm? We don't know what the percent risk of rupture at 2, 4, 6, 12 hours is between these injuries, and we still don't know that today. A couple of simplified algorithms and systems have been developed to try and understand or at least categorize these injuries, but none have been standardized across all injuries and across all hospitals. So at our own institution, some of my colleagues looked at some other associated factors, other associated findings that come with blunt thoracic aortic injury in an effort to try and determine which patients really need treatment quickly and which ones do not. So the grade 3s, those are the pseudoaneurysms with what they consider secondary signs of injury, or SSI. These suggest urgent repair. These are the ones that we don't want to wait on. So grade 3s without SSI, you can consider delayed repair during the hospitalization or even just initial medical management. So pseudocoarctation, mediastinal hematoma, and large left hemothoraces are all secondary signs of injury. So if you have a grade 3 with any one of those 3 findings, it is recommended that you do undergo repair rapidly, whether that's 2 hours or 4 hours, but it's not something you want to wait on for just prior to discharge, or certainly bring back after hospital discharge, and it's not someone that you want to just start aspirin on and leave alone. Grade 1s and 2s, not surprisingly, the small intimal tears and the intramural hematomas. If those have secondary signs of injury, then you should consider, but it's definitely not mandatory to repair these. So what an optimal grading system should do, obviously determine treatment, tell us what grade needs what kind of treatment, whether we should be treating with medical, TBAR, endovascular, or open repair. It should guide the timing of treatment, again, how quickly do we need to do this, and also guide the prediction of the natural history. So when we sit and look at these grade 3 pseudoaneurysms, we don't know the natural history. So we don't know how long it'll be before they rupture or whether they will even rupture at all. The Aortic Trauma Foundation was started several years ago. My colleague Joe DeBose started it with some of his vascular colleagues in Houston, and it is now in a multi-specialty scientific advisory board that has been spearheading a study on blunt thoracic aortic injuries and TVARs. So this group consists of vascular surgeons, CT surgeons, trauma surgeons, and radiologists, really anyone with a stake in treating these patients. They did a study initially looking at 9 level 1 trauma centers, sent out a survey, and also collected data on 453 patients, and 382 of those were included in the study. Again, they were just looking as an observational study, really on how patients are treated, how many patients, again, most of them have grade 3 injuries. The pseudoaneurysms are the most common. CT alone was 95% used to diagnose the injury. And a significant amount, 25 to 30%, had what we talked about before, those secondary signs of injury. Obviously, some significant complications occurred, not surprisingly, and the overall mortality, 20%, and aortic-related mortality was about 6.5%. So looking at the non-operatively managed patients was about 32% of those, or 123. The non-operatively managed patients were older. They had about 3/4 of them were grade 1 injuries. Again, those tiny little intimal tears that don't require any surgery for repair. They were less likely to have associated signs of injury on CT, but they did have a higher overall mortality. There were 2 failures, a grade 1 and a grade 4. They both underwent TVAR. For the repair, open versus TVAR, 16% had open and 51 had TVAR. So that's, again, just demonstrating the huge adoption of endovascular technology for this treatment. And up to today, we would say that the TVAR is essentially the standard of care for blunt thoracic aortic injury if the lesion is amenable to endovascular treatment. There's still some lesions that we can find. They're certainly rare, but if they are too close to the origins of vessels that cannot be covered, and I don't mean the subclavian because we can certainly cover that, but there are some lesions, very, very few, that are not amenable to endovascular repair. So TVAR patients compared to open repair, older, lower ISS, had fewer secondary signs of injury and required less FFP. The TVAR patients, the stent graft patients, had a lower overall mortality and a lower aortic-related mortality as well. So this was just an example of the cross-section of devices that were used. This is different depending on which cohort you study, which hospital, which attending. Everyone has their own specific devices that they're more comfortable doing these procedures with. Definitely a range and diameter of devices and the device lengths as well. So there were 40% that were greater than 10 centimeters, which is quite long. Most blunt thoracic aortic injuries, the actual lesion is quite short and does not require a ton of coverage of the aorta, which is why we're seeing less and less paraplegia as we move along with TVAR. The endovascular repair outcomes were certainly acceptable. Low rates of stent fracture, migration, access site complications were not zero, but essentially quite small. And then a treatment failure of 3% for the TVAR group. There was paralysis after one TVAR, but if we look at the centimeter length of coverage, it's 20 centimeters covering the thoracic aorta, which is certainly problematic. And as I mentioned, most devices, either a 10 or 12 centimeter length is adequate enough to cover most blunt thoracic aortic injuries. This was an elderly patient. There were 2 strokes in that study. For the SVS, the Society of Vascular Surgery for grade 1 and 2 injuries, which is intimal tears and intramural hematomas, there was no difference in outcomes for patients treated with non-operative versus TVAR for grade 1 and 2 only. The SVS presently recommends treatment for grade 2 injuries, which, if you look across institutions, is still debatable. Aortic-related mortality, there were 25 overall, all but 7 occurred prior to the opportunity for repair. And then deaths after attempt at repair. So there were 2 grade 2s, 2 grade 3s, and 4 grade 4s, but all were severely injured. All had severe abdominal AIS scores, and 3 had GCS of 3 on arrival. So these patients that have blunt thoracic aortic injury, it is very rare that that is the only injury. There are often competing injuries. It makes it problematic. We can't use heparin in the patients that have TBI. It makes it extremely difficult and challenging really to figure out where in the whole algorithm, the treatment algorithm, where are we going to repair these patients, and do we actually need to, or is it not wise to do? Deaths after attempt at BTAI repair, there were 4 open surgical repairs and 3 TBRs. 5 died within 24 hours of admission. And then there were independent predictors of all-cause and aortic-related mortality among blunt thoracic aortic patients, and they are listed here. There was a survey done by the members of the society, really through SVS, WST, East, STS, and SIR. And this is really just a kind of a big grab bag, trying to figure out who does what the contemporary management of these injuries are. So most were trauma and vascular surgeons. And really the question that came up was, once the diagnosis of blunt thoracic aortic injury has been made, how do you determine which patients actually require repair? And the most significant answer was a personal knowledge and experience of this injury. It wasn't the data, it wasn't because someone said so, it was personal knowledge and experience of this injury. So not surprisingly, for most people would not treat a grade 1 injury except giving medical therapy. For grade 2, it was actually split. Half the group said I would treat with medical therapy, half the group would do a TVAR. Grade 3, almost everyone, not surprisingly, as we've talked about, does a TVAR, and grade 4 also does a TVAR. So again, demonstrating that even in a grade 4 injury, this is a ruptured aorta, people are still going to pursue TVAR as the treatment of choice rather than open repair. So another example of the contemporary treatment change. The Western Trauma Association put together a multi-center study, looked at patients from 8 centers over a 10-year period, and took a look at TVAR versus open patients, again demonstrating what we have seen in other literature, that the TVAR patients are doing significantly better, especially in the short term. The problem with the TVAR is that they do have somewhat of a rate of complications and require re-intervention. That is the most significant complications that those patients have. The actual procedural complications, overall about 9% in the TVAR group. There were 9 type 1 endoleaks. Those are fairly significant. That's when blood flows around the top of the graft and gets into other vessels. The stent graft can collapse. That's also significant because that prevents blood flow antegrade where it's supposed to go. Access complications and migration. Neurologic complications, again, just like the WAST studies, were significantly less. So the conclusion, again, was that TVAR has become the standard of care based on short and midterm follow-up, but follow-up is extremely difficult in our patients, right? Trauma patients don't come back to see us very often, and those that do certainly don't come back when their appointments are. So we looked at our own single institution experience with TVAR and looked at from really the very beginning of endograft stent repair in our own institution, and looked at 11 years worth of data and looked at the grades according to the SVS criteria. So we looked at 88 patients. Again, the majority had grade 3 injuries. The major in-hospital complication rate was pretty high. That included pneumonia, PE. Remember, these patients come in with more than one injury. They're injured in more than one location. TVAR-related mortality was 0, and overall hospital mortality was 6. But again, these patients had other significant injuries, liver injuries, TBI. Paraplegia and stroke rate was 0 in our series, and those, again, demonstrating a decrease in rate since the 2008 WST trial. It is consistent with recent reports in the literature, and it probably has a lot to do with the fact that the coverage of the aorta is much, much shorter. So a 10, 12 centimeter coverage of the thoracic aorta is well tolerated by most patients. The percutaneous Tbr, for those of you that are familiar with percutaneous access and closure devices in vascular surgery, we started to use this system in our trauma patients. It's actually quite ideal in patients with healthy arteries. It doesn't work, these closure devices don't work as well when there's a lot of plaque in the arteries, which is most older patients and patients with vascular disease, but it worked very, very well in our young trauma patients. And we used that in the final 10 consecutive patients in our series, and there was no significant access complications. So the issue about heparin, right? Most people with a sheath in their groin the standard routine is to bolus heparin throughout the procedure, but SVS recommends heparinization in smaller doses in trauma. However, in our series, 23 patients with TBI were given heparin during the procedure, and 10 patients had the procedure without heparin, and there was actually no adverse event whether they had heparin or not. So it was actually safe to use in TBI, but if we didn't use it, it was actually also safe as well. There were no thromboembolic complications. So really the decision there is that heparin should be individualized per patient. So it should be a multidisciplinary discussion, neurosurgery, trauma. Everybody should have their hands in the game and decide how to deal with these patients and whether heparin is a good idea. The question about upper extremity ischemia, can we cover the subclavian artery? Does it even matter? We covered it in 19 patients and partially in 7. There were 2 carotid left subclavian bypasses that were just done prophylactically, one because a patient had a cabbage. There was no postoperative ischemia, and revascularization only occurred if necessary. Again, this was a preoperative revascularization because the patient had a cabbage, and obviously if you have a patient whose coronary flow is dependent on your antegrade subclavian flow, please do a revasc prior to the operation. In terms of complications, very minimal, especially compared to the previous literature. All the endo leaks were minor and resolved on their own. The overall TBR reintervention rate was 4.5. So if you remember the AAST trial, the very first one, the initial one, was up to 20%, so we're certainly getting better. And open conversion, so from endovascular to open conversion, was only required in 2 patients. There was a reduction in endoleaks and major vascular injuries, and a higher rate of endoleak observation and resolution. So we were able to identify the endoleaks, but there was no intervention required, and especially after 2009. And again, that was just a chart that we looked at, the AAST trial in comparison. Follow-up, of course, cannot understate the post-discharge surveillance is a problem in our population, but no device-related complications were identified on CT, and no patients returned with complications. So I can't talk about TBR or endovascular without mentioning for one slide where this all started, not just for me personally, but also for endovascular as a whole. For those of you that know the area, obviously, in the hospitals, I spent 6 months at Arizona Heart Hospital back in 2011 with these phenomenal attending physicians who taught me TBR and Reboa and really pushed the limit, and I watched them day after day push the envelope with endovascular surgery, and they have a lot to do, especially Dr. Diedrich has a lot to do with where we are today with endovascular surgery, and so I have them to thank for a lot of the things I do, and I think about them often. Follow-up studies in terms of TBR, what do we do about the young patient, the 18-year-old with a small aorta, we're sticking a stent graft in, what's going to happen 30 years later? What happens when their aorta grows? So there's one great study that talked about basically where the proximal landing zone is and the distal landing zone is. It's a study from France, and they measured the proximal landing zone and the distal landing zone 10 years after their initial repair. What they found was that there was a slight, like maybe a few millimeter increase, mostly at the proximal landing zone of the proximal descending aorta, that grew over a 10-year period. However, there was no clinical significance for this, so it didn't result in endoleaks. The stents didn't migrate, they didn't collapse. So the answer to the question, are these TBRs going to be safe in 30 years? The best we can answer is that 14, 15 years out, maybe 20, but we just don't have enough data yet because it just didn't become a routine standard of care until about 15 years ago. Thank you very much.